So you're all very welcome. It's good to have a chance to present something from the north, from the Palliative Care Research Forum for Northern Ireland. We haven't been very active this past little while for, I suppose, for obvious reasons, but it's good to have a chance to put together a few things for you. And I'll say a little bit about some work that I've been doing, and then I'm pleased to share with you some of the findings from Anita Mallon, who's here to share her PhD, which is about engaging younger people in awareness of palliative care. And Lisa Graham-Weisner from Queen's Psychology Department will be speaking about some of her recent work, also engaging the public and public awareness around palliative care. I'm hoping that at the end, Loretta Gribben will have a few words from the Public Health Agency regarding some of the work that's going on in policy, at the policy level. So I'm not going to say too much more other than to share a couple of slides regarding some work that's complete now, looking at palliative care day services, which there's a team worked with me on this, and I'll just try to share this first one, which is the literature review, which formed part of that study. Hopefully you can see it's a poster actually on outcomes of attendance at palliative care day services, a review of the evidence. So palliative care day services is one of the very earliest types of palliative care that people experience when they're still living at home and they're offered a weekly or a regular attendance at a day service, typically at a hospice. And the intention is to support people whilst maintaining them in their own home for as long as possible. So the literature review updated a previous systematic review and helped us to get going with the project. And you can see the findings, I think. There were 4 topics that came out of the literature. That day services provides a unique environment centred on interaction and centred on supporting people and addressing their needs. It provides a safe place for patients, but also provides respite for the carer during the time that the patients are in attendance. There was evidence from the literature that there's a sort of a crossroads now, that the services are becoming more specifically goal-oriented or to address patients' specific needs, rather than formally, which it was more of a social support mechanism. So there's a bit of a change. It still includes psychosocial as well as clinical supports, many different kinds of supports, as you might hear about as we through the rest of this work. I'll not be able to cover it all today, but this is just to give you a bit of a flavour. So day services has a sort of a special role in this public understanding arena to try to let people see what's possible, and because it's almost always the first point of contact. So the plan now is to go on to the next one. If I can find it. It's very similar looking, but you should be able to see it. It's exploring 3 types of palliative care day services in the UK. This was done in partnership with many partners in Belfast, in Edinburgh, and in Birmingham. This was 3 Marie Curie centres. I suppose I was expecting them to be similar, that we would see some variation, but we would, because we were within a common management structure, you would expect them to be somewhat similar, but in fact they're quite different. The local context and the local setup was different in each case. Even the referral patterns are different. So this particular outcome is about trying to learn from the health economists. So these authors are health economists, Paul Mitchell, Gareth and Joe Coast. looked at the data from a costing perspective, and if you go straight to the findings, you'll see that, first of all, a very small number of cases. I was disappointed that we were only able to recruit 38 cases across all 3 centres over the study period. I think we were a bit tight with our inclusion criteria. We were a bit short with the recruitment period due to various things and delays with getting approvals. Anyhow, we had a limited number of cases that were followed right through, and we got figures on the cost. You can see the cost in euro there. The cost per patient per day ranged from £200 to £300. So that hadn't really been established clearly before. So we've got some idea of the cost. And then the second main thing from this analysis shows that the volunteer contribution is quite significant. Now that's assessed in this study as an input in financial terms. Even though they're volunteers and are not paid, they're still, the economist is able to quantify the amount of input that they made to the service to be over a quarter, and as much as 38% is over a third. So a very substantial financial equivalent is there to make this service happen. So the volunteers helped in a number of ways. I think primarily in helping with transport and getting people to the service and home again. They also have a volunteering, a helper role during the day service as well. So not as much as we had hoped really from this particular part. There will be other dissemination, other findings from this. We still have to finish the chart review, which was quite successful. Chart reviews and looking at patients' notes, quite a useful way to do research, so that recruitment is not so much of a hassle, and you can get hold of the data subject to approvals, of course, but I'll report on that another time. So day services, there you have it. It was quite a bit of work. I think it's useful for those who may be looking at setting up day services. I've had 1 or 2 contacts with people to try to explain how the local context is so important, even within the one organisation. The local context, the local need, how far people are prepared to travel, what other services are available to them in their own home. There are lots of important influences that I think we're able to say something about. Okay, stop on that, share, and now invite Dr. Anita Mallon to her presentation. This is a PhD now that Anita has finished not so long ago. It's going to come up on the screen, and it's and how we engage younger people in the whole idea of palliative care. So, Anita, over to you now.
Good afternoon, and thank you for joining us. My thanks to the All-Ireland Institute of Hospice and Palliative Care and to the Palliative Care Research Forum for Northern Ireland. I'm delighted to get this opportunity to share some of the study findings from my PhD, which I finished back in February time. The title of my study is Examining Young People's Knowledge, Attitudes and Perceptions of Palliative Care within a Public Health Context. This was a mixed method study. During the week, I posed the question, why would you ask young people about palliative care? This was a question I was asked frequently throughout my PhD, and often disapprovingly. My answer is that young people need to be aware of significant health issues that may affect them throughout the lifespan. The magnitude of palliative care need and limited access is a pressing issue, not only for our health and social services, but for all of society. A public health approach to palliative care has been suggested to extend the reach of palliative care. Through this approach, we'll be looking much more at communities and at populations for solutions. However, this assumes a community that knows what palliative care is, that can understand the caregiving, and also can in some way contribute to that care. Yet the literature shows a variable understanding of palliative care, and the views of young adults who aren't planning a career in health have not been gauged in relation to palliative care. Yet we do need their views. As young people in multiple roles, as citizens, as patients, as carers, as professionals and future professionals, we need their views on the design and evaluation of services, as advocates for the priority resourcing of palliative care, but crucially as members of a knowledgeable and responsive community. Now, the population that we recruited for this study were university students aged 18 to 29 years from Asia Pacific University and across all faculties. This cohort were chosen because they're a significant group of the young public, and also because it had never been done before with any groups outside healthcare. So I'm going to concentrate on a few questions. What do young adults aged 18 to 29 years know about palliative care? What influences that knowledge? Do they want to know more about palliative care, and how can the message be delivered? Now, this is going to be a whistle-stop tour through the methods. So phase one was the lengthiest phase, and this is where I did a general scoping, went out and talked to young people's groups within the university and outside, to people in public health and palliative care, and did an in-depth literature search and analysis relating to the public knowledge and also the knowledge of specific groups of young people. So a 42-item online survey we developed. The first 13 questions related to knowledge of palliative care. And this was measured with a validated tool called the Palliative Care Knowledge Scale. This was developed specifically for the general public by Kozlov in 2017. The second section related to attitude items, and this was how they felt about engaging with the subject of palliative care, how they felt others, felt about it, and how they perceived their future engagement with it. But then the third section was on demographics and experience. And the analysis was done on a total of 859 complete data sets. So from the survey, the interviewees were recruited. In total, 24 interviews were undertaken, 17 face-to-face, 5 via Skype, and 2 through the telephone. And then, just in conclusion, the 3 phases were then brought together and combined to give a comprehensive understanding of young people's views on palliative care. So participant demographic characteristics. So the majority of the students were on full-time courses and were undergraduate. There was an overrepresentation of those identifying as female, and how the characteristics differed from the university characteristics was, again, that 75% female. And whenever I look at the literature, you see that 3-to-1 ratio is really something, especially in groups of young adults, is something that seems to occur quite frequently. I suppose, as you would expect, the Faculty of Life and Health Science, there was 50% took part from that faculty. What also was notable was the amount of students that didn't affiliate with a religion by comparison to the university statistics. So how familiar were they with the term palliative care, and what was their experience? 83% had heard of palliative care prior to the survey. 36% were unsure if they or someone close to them had received or accessed palliative care. And 33% had cared for someone at the end of the life. So when this was explored through interview, what became evident was that there was no firm source of palliative care knowledge. Some people had a vague idea if it had been discussed in families in conversations to which they weren't party. They were very much outside as bystanders, trying to pick apart their understanding of palliative care. Others got their knowledge from courses, some from clinical experience, and very often some of that knowledge was vague. They just weren't quite sure. It was like cancer. It was a word that they'd heard of, but they weren't sure from where. So what do young people know about palliative care? And I explained that we used the palliative care knowledge scale in order to determine what the knowledge was. This is 13 statements relating to the delivery, the timing of palliative care and populations. So I'm going to deal with really the three most striking findings. And the first one was palliative care is exclusively for those in the last 6 months of life. This had the highest level of I don't know reported. And this is something that I've found throughout for most of the 13 items, was the high levels of I don't know. And whenever we looked at that and familiarity with palliative care, we found that those who were less familiar did actually score I don't know. I'll come back to this later in the joint display. The second one is palliative care is specifically for people with cancer, and that had the highest accurate answer reported. And that seemed quite surprising. Again, I'll return to this. And the third one is a goal of palliative care is to help people understand their treatment options. So this had the highest inaccurate score. So whenever I actually looked at this again at interview, and we were discussing the treatment aspect, the active part of palliative care, I got the impression from participants that palliative care was seen very much as something to which you succumbed rather than something that you actually actively chose. It was when everything else was exhausted. It represented inactive care in that no further discussions. Even some of the respondents who were really very positive about palliative care, when they related their own experience, and this respondent did, of someone very close to them when they found out that they had terminal cancer, what they thought was, I knew palliative care was coming. There would be no operations, no chemo, no nothing. So what influences knowledge of palliative care? So this is the statistics. So those identifying with a female had higher scores on the PACS tool, those in the Faculty of Life and Health Science, and those in the older age groups. The mean score was 9 out of 13, so that would seem really quite a high score on the knowledge scale. But we have to remember that this scale was also, the more literate you are, the more likely you are to score higher on this scale. So you'd expect a university population to have a high score. But when all of these demographics and the familiarity and attitudes were all placed together into a statistical package, what we found out was that the top predictor of palliative care knowledge was familiarity with palliative care, and attitudes and perceived knowledge also came up higher. So these demographics were actually knocked out, and this has implications for practice, because really what it's saying is it is so important that people are the holistic assessment of people, that we don't just look and make assumptions relating to gender. Oh, that person is studying in healthcare, or that is an older adult, because an awful lot depends on life experience. So that has to be part of the assessment process. So I said I would return to the two questions from the PACS tool that actually were surprising. So it was surprising that so many people said it was false, that palliative care is exclusive for people who are in the last 6 months of life, because other knowledge studies have found that very much it is associated with the end of life. And what 22 out of the 24 interviewees said that palliative care was end of life care. It was last days of care, terminal care. So palliative care was positioned firmly at the end of life, but for two participants. One who brought the words together through a dictionary, and the last person who actually said they talked to someone who had received a specialist palliative care, and they said it was long-term illness. It was not you dying. So the source of exposure to palliative care determined where participants positioned palliative care. There were no standardised sources between and within faculties, with participants just piecing together when palliative care might be required. And another interesting finding, again, and something that was contrary to other population studies, was that the majority felt that palliative care was not specifically for people with cancer. However, throughout all of the interviews, whenever the participants were relating their stories, they were related in relation to cancer. There was, you know, an awareness that palliative care was for other diseases, but their exposure was mostly cancer related. They did talk about possibility of Alzheimer's in older age and frailty, but cancer was the one certainty. What both the students in clinical practice and the lay public seem to be saying in their communities is palliative care's association with cancer. The breadth of illness that is associated or advocated by the World Health Organization didn't seem to be realised by these participants. So this is really just showing you how the two methods of data collection actually brought a much more comprehensive understanding of the participants' views. So did they want to know more about palliative care? Yes, 7 out of 10 did want to know more. Over 50% want to know what palliative care initiatives were taking place in their community. 36% only knew where to find information on palliative care if needed for themselves or a loved one. And 62% felt it was important to find out palliative care so they could plan ahead. So what did they want to know? What exactly is palliative care? And I'm going to just present each of these with a quotation. I suppose exactly what it is and how you can get in touch with people if you feel that somebody needs it. Who provides palliative care? Could anyone join? Does it have to be someone that is a registered nurse or professional? Can it be volunteers coming in and spending time with people? And these participants felt that young people had youth, had energy and had time that they could actually give if they were engaged. What are the outcomes? When these steps are introduced, what result does that actually have for the patient? And they want to know, how does that compare if palliative care wasn't introduced? And finally, how to manage relationships? How to support someone going through it without the disease, the issues hanging over the relationship? And that was something that really came up a lot more with male participants who wanted to be able to do something active. They wanted to be able to make the situation better. And not having that, what they perceived an ability to make it better, but they then were shying away from any engagement with the subject. So moving forward, this is how participants suggested that you get young people interested in palliative care. All the information in the world could be there, but it has to be made relatable. So whenever they discussed public health campaigns, they said it was important that they didn't ward people off behaviours as they would associate them with, but more try and encourage it. Using young people's testimonials, using young people from both genders, normalising death and dying through early introduction. And this was a very popular a suggestion, that really if people earlier on knew about palliative care and understood the issues relating to palliative care, that it wouldn't come as such a shock, and it would provide them with a brace, with a mission plan for later. Use the education system as a platform. And this is where they felt the environment was safe. They were able to have safe discussions without offending people. Provide the message in simple terms without emotion. And again, this was very popular. What is palliative care? Where do you get palliative care? What can we do? And immediacy, they wanted to be able to consume this information in a minute. The use of arts projects, flyers, testimonials, media and social media especially, was suggested as the platform for information. Now, I suppose looking at this as to the implications for practice, this has implications for public health and palliative care regarding the monitoring of information that's there and the presence on social media. And lastly was messages of hope that provides roles, opportunity and connection. There was a debate between participants as to whether or not palliative care should be taken away from death and dying and just put at the end of general illnesses, or whether death and dying should really be made more acceptable within society and a universally discussed topic. So, in conclusion, these participants were aware of palliative care. They knew some of the core concerns of palliative care, but they looked at palliative care as inactive care. They didn't see the rehabilitative aspect of palliative care. to return to the question that I asked at the start, well, why would we ask young people about palliative care? Young people, if we deny them the opportunity to engage with palliative care through some sort of a protective society, what we're doing is we're preventing them from the opportunities, from developing skills, making connections, to become compassionate friends, compassionate neighbours, and really knowledgeable citizens. And I met a lot of very compassionate young people throughout this PhD journey. Thank you very much.
Okay, thanks very much, Anita. I think there may be a question in the chat box, and there'll be time later for questions if we get time. I'm hoping to pass it over now to Lisa. Let me see. Lisa, are you there? Lisa Graham-Wisner is going to say a little bit about some recent work on a wider public perceptions around as you will be able to see, talking about death and dying in Northern Ireland. Lisa, are you able to take control?
Hopefully. Yes, that's doing okay. Okay. Thank you very much, George, and thank you everyone for having me here today to say a few words. It's lovely to be with you, albeit virtually, and to see lots of familiar names and some new names as well. So I'm Lisa Graham-Wisner. I'm a lecturer in health psychology at Queen's University, and today I'm really hoping to speak about a piece of work that fits within this public health approach to palliative end-of-life care, and specifically is around public perceptions of talking about death and dying in Northern Ireland. And before I go any further, just to acknowledge my collaborators in this. So I worked with Dr. Emma Berry, who's a colleague at Queen's, as well as several colleagues through the Marie Curie Institute at Cardiff University, and my colleague Craig Harrison, who is through Marie Curie Northern Ireland, and also to acknowledge the funder of this research, the British Psychological Society as well. So as some of you may know, there are several different public health approaches to palliative care, one of which is the health promoting palliative care approach. So this is a model which was established in the late 1990s, and really advocates for a shift away from social model, or a shift towards a social model of end-of-life care. So it's around really placing death, dying and loss within the community context of everyday life. A key principle of this is around building social capital, so building community capacity towards supporting those at end of life. And one of the proposals by those that work within this approach is that, along with the development of statutory palliative care services the last few decades, we, particularly in Western nations and certainly within the UK, have become diminished in our community capacity to support those at end of life. And it was Rosemary Leonard who proposed this question, whose business is dying? And within this palliative public health approach to palliative care, it would say that all of us have a stake in caring and supporting those at the end of life. Now, one of the ways to facilitate this, which is really around facilitating the preparedness of communities, is around building death literacy. And death literacy can be defined as a set of knowledge and skills that make it possible to gain access to, understand and act upon end-of-life and death care options. And one facet of death literacy is talking support. So this is around our ability to provide support to others in discussing their own wishes and preferences at the end of life, and also to be able to discuss our own wishes and preferences. And I think there's an acknowledgement within palliative care that we don't talk about death and dying enough. As a society, we don't talk about death and dying enough. So this is something that I was interested in looking at. What is the perception of the general public in regards to this? So most of the research that's been conducted to this point that has looked at barriers and facilitators to talking about death and dying has been more specifically within the context of advanced care planning, more than anything within the context of clinical populations or even healthcare professionals working within palliative care settings. But there was a call a few years ago that we should also be looking at the likes of hidden publics and younger adults. So we should be looking at discussion of death and dying from the perception of whole populations. So this is really what we sought to do. We sought to look at what the barriers and facilitators were to talking about death and dying in a UK region, so specifically in Northern Ireland. And to do so, we developed an online mixed methods survey. So this survey, it's 41 items long, and it was developed off the back of the James Lind Alliance Priority Setting Partnership in palliative and end-of-life care that was conducted a few years ago, and it was further refined by a group of patients in the public in Wales and then adapted to our context in Northern Ireland. It's mixed methods, so we had a range of both quantitative and open-ended questions within this. And we recruited participants using social media. This was last year, so it was between January and April 2019. And this was open to the community in Northern Ireland, and we defined community as adults currently living in Northern Ireland. That was it. One of the questions that we asked was, as a society, how much do we talk about death and dying in Northern Ireland? And you can see from the figure on the right there that the vast majority of respondents, and we had about 562 respondents for the entire survey, said that we don't talk about it enough. So 70% said that we don't talk about death and dying enough. We then posed a few follow-up questions to this, one of which was how do you think this can be increased? So if you don't feel we talk about death and dying enough as a society, how do you think this can be increased? And we analysed this data using a type of reflexive thematic analysis. So I'm just going to run through a few of the sub-themes that came out that I thought were particularly pertinent to the other presentations today. And to say first about the sample characteristics, so we had 385 participants that responded to that question. As you can see, participants weren't reflective of our population, so more women than men again volunteered to take part in this. Of a younger demographic as well, and most of the sample had quite a bit of formal education as well. But actually a minority considered themselves to be within the last few years of life. So on several characteristics in particular, we felt that we had quite a broad perspective captured here. So one of the themes that came out was around the importance of increasing knowledge of the death system and in particular education along the life course. And this really was the precursor in which to anchor these conversations around death and dying. So participants described discussion around death and dying as being a taboo, but something that's not inherent, but rather develops in each of us across the life course. So they viewed it as being a social construct. And alongside that, they also saw that there was opportunity there to normalise death and dying through early intervention, so intervention with young children. There was a description of really the need to embed these discussions within formalised curricula within primary and secondary education, though tertiary education was also mentioned. And quite a few participants recognised that really we need to have parity in discussing death and dying with the likes of sex and relationships education. So they very much saw this discussion as being encased within that focus on personal development within curriculum within schools. Several developmentally appropriate topics were suggested for the likes of younger children. So grief and loss was most frequently cited. I mean, I know this is an area that is of interest to a few organisations within Northern Ireland, and also Dr. Sally Paul, who I believe is a speaker at the upcoming public health seminar that the All Ireland Institute are hosting in November. She's done quite a bit of research in this area as well. But the focus wasn't just on younger people and younger adults. It was very much around education from cradle to grave. And I find it particularly interesting how education was cited frequently. So it wasn't information provision. Very much so, it was this term education. And one of the suggestions was around public discussions, so workshops and seminars. And there were some common threads there in terms of the sort of caveats or sort of essential ingredients for success in regards to those workshops. So participants felt that there needed to be ownership from organisations perceived to be experts in this area, and I would say that medical charities were most commonly cited. And they also saw that there was an opportunity to embed those discussions within existing communities. So an example was given as being workplaces. Also within this theme of increasing knowledge of the death system was the importance of experts sharing their experience and this perception of privileged knowledge as existing in relation to death and dying. And I think that's something that all of us are probably familiar with. And really the need for experts across various different sectors to try to act as knowledge brokers towards sharing both process and experience-based knowledge with the community. A diverse range of expertise was recognised, so it wasn't just healthcare professionals, it was also funeral services staff, financial advisors, and importantly individuals with lived experience of the death system, so individuals with a diagnosis of a life-threatening illness and also their close persons. Was also quite a good focus on storytelling and the importance of storytelling, which I think speaks to our rich cultural heritage within that, and I think that's something that the All Ireland Institute do very well, particularly around Palliative Care Week each year, where they highlight patient stories. Another theme was around improving interpersonal communication, and something that I thought was particularly interesting was around the need for increased awareness of individual differences. So participants felt it may be helpful to avoid emotionally laden and dogmatic topics which could arouse conflict and also discomfort. So there was this emphasis that was placed on approaching the topic from the perspective of human understanding and being sensitive to participation of people with differing belief systems. Disappointingly, there were a number of participants who said that they felt that they had been excluded from these conversations in the past because of their particular belief system. So the emphasis here is really on approaching it from a universal perspective and in an inclusive manner that allows participation both across religious denominations but also for those who are non-religious as well. And I think this is something that I know came out very strongly in our own findings. The same question was posed to the general public in another piece of research in Wales, and it wasn't a prevalent theme. So there may be some societal differences there. Now the last theme is really around encouraging acceptance of the need for death talk. So this is around changing attitudes, and a sub-theme within that was around normalising death as a natural part of life. So normalising as a natural part of the life cycle. And this concept of death positivity came in quite frequently as well. And participants saw the opportunity as well with this focus, with adopting positive focus to death, is also helping individuals to reflect upon their own life and how they may live meaningfully and also mindfully as well. And again, within this sub-theme, the importance of early intervention and speaking with children, younger family members came out. This in this sense, not from a curriculum perspective, but the role we all have in terms of speaking and discussing about death and dying and loss with younger family members. So there was a perception that we shield children and young people from, for example, information on family members having serious illnesses, and we also hide our own grief from them as well. And we don't include them in various death rituals such as funerals and wakes when we could. And participants viewed this as a lost opportunity really in terms of us being able to normalise our emotional reaction to death and help younger people build up death literacy from an early age. So just a few points to really bring this to a close. These are statistics that I'm sure you've seen shared a few times this week, that our local death rate in Northern Ireland is projected to increase at a faster rate than other UK nation states, and aligned to this, we have a greater palliative care need. So I suppose the question is, does this represent a more pressing need for us as a region to develop our community capacity around providing support at end of life? The second point I'd make is that although I think there are a lot of common threads in terms of what we find whenever we ask the public in Northern Ireland about their reasons for not and for talking about death and dying with other research, but I think as well there were some more unique aspects as well, and this comes down to the importance perhaps of tailoring public health campaigns and interventions around the likes of talking around about death and dying, but also advanced care planning to the context at hand. And lastly, I mean, I'm very interested in how different disciplines can work together to help promote, for example, conversations around advanced care planning. Essentially, what we're looking at here is changing behaviours and changing a range of different behaviours. And one of the questions for me is if we can borrow some of the approaches that are used around modelling health behaviours and building that sort of theoretical understanding to help us to inform evidence-based interventions and public health campaigns. And also in relation to that, I know that there's a lot of exciting work out there in relation to public health campaigns and workshops and death cafes across the country. And how do we measure when there has been an impact? So often what we're seeking to measure in those contexts are, has the person written down their wishes, have they changed their behaviour? But behaviour can be difficult to change. And actually in those cases, what we are more interested in perhaps is have we changed their death literacy? So at present I'm working with a few colleagues on validating and benchmarking and measure of death literacy, which should be freely available and I hope in the near future for us to use within the UK and Ireland. So thanks so much for your attention, and I'm just using this last slide to highlight the excellent work of some others in this area. Thank you.
Thanks very much, Lisa.
Just a couple of things to put in perspective for colleagues on the call who may not be familiar with the palliative care and partnership approach, but really I would really want to endorse the need for a public health approach to palliative care, and to that end there's been a fair bit of work done through the partnership programme, and you'll see with a number of partners, many of who will be on the call today, looking and this work has been driven by the Palliative Care and Partnership Programme and colleagues in the Department of Health through the Innovation Lab. A number of workshops have been done looking at how we actually embed palliative care conversations in the public health agenda and in societal conversations, and to that end it's been really interesting to listen to Anita and Lisa and your own, George, your own findings around the sort of taboo in inverted commas. I think we certainly have more work to understand if it is a taboo or if that's just a societal construct that we can need to be working at, and together a lot of us can achieve inroads into this. So really I suppose to remind ourselves that and I always like to quote Dame Cicely Saunders. She's one of the founders of the whole hospice movement and the importance of that we as individuals, so everyone in our society matters because they matter to they matter to the last moment of their life, because they matter because they are that individual person. So again, within society we have a piece of work, quite a large piece of work to do around individuals in society being given the opportunities to do that advanced thinking, to have their advanced care planning discussions, and for us then, and certainly this would be a big driver within the programme, that those advanced discussions are mobilised. And to do that effectively, and just reflecting back on the work that we've done with the Innovation Labs and that strategic work that we've done, we did engage with much wider audience obviously than health, because the ACP work is much bigger than health. Health is one element of it, but out of the work, and again just the direction from a policy perspective, would be that there is a real need to link with education authorities around palliative care and embedding it in curriculum. We need much more inclusion and working with the councils, the community planning and development opportunities within the community sector. And again, I know there's many colleagues on the call who will have been party to those insight workshops, and there's been some very rich data that has come through that in a report. I can't share it with you today nor after the event because it has to go through our programme board structures and our governance arrangements. There's a real need to have the conversations across generations. It was really interesting, Anita, to get your perspective from the younger person, because again we had a recent at the Balmoral show a year gone, we had a public awareness raising session around ACP. We used Your Life, Your Choices, and the engagement we had from young people was really, really amazing. They had no difficulty in talking about death, and they were actually very engaged in the whole discussions on the day. So that was really heartening. There's a need also to have the conversation, you know, using our existing networks. There's lots of good work going on there, and I know again colleagues on the call are already involved in a lot of good work, and I'm thinking about the work that Dee's involved in around the heart of living and dying. I think that's the right name, Dee, forgive me if it's not. So there is a need to build on all those excellent work that's happening at the minute. The advanced care planning, there is a piece now been driven by the department looking at advanced care planning in its widest context, and there's going to be work done to develop an advanced care plan policy regionally. So there's a need as well to engage with other, as I say, organisations outside health. We've talked about education. There's also clubs, churches, social clubs, the whole voluntary sector that's out there doing so much good work as well. And again, just finally to say that we need to mobilise and exercise any of your life, you know, the usual life event triggers. So the likes of, you know, new house purchases, the likes of will making, the likes of just life choices in general, and to create the opportunities of when we can have those opportunities about future plans for our care. So very happy, folks, to support any work in the space of the public health in terms of it's the same direction. We're all on the one page. We're all in this together, to borrow the hashtag of this week of palliative care, and together we can improve the experience for our society in terms of living with dying. So thank you for this opportunity, and happy to be part of the panel now. So thank you all.